Janet Laird. I'm a nurse practitioner at Appleton Area Health Center, and we're here to talk about cardiovascular disease. Cardiovascular disease talks about coronary heart disease, stroke, and peripheral artery disease, as well as diabetes, type 1, type 2, and pre-diabetes. Cardiovascular disease is common in the general population, and it affects the majority of adults past the age of 60, although people can have cardiovascular disease under the age of 60 as well. As a diagnostic category, cardiovascular disease includes 4 major areas, and that's the areas I just mentioned, which are the coronary heart disease, and it can manifest or come about in the way of having a heart attack, having angina, which is heart pain, people call it, heart failure, and coronary death. Cardiovascular disease can be manifested by a stroke or a trans-ischemic attack. A trans-ischemic attack looks like a stroke, but it comes and it goes. And it's usually a warning sign of an impending stroke in the near future. Peripheral artery disease is manifested by intermittent claudication, which is a circulation problem to the lower extremities. And we will have time at the end for questions if you guys want to ask some questions. Aortic sclerosis and thoracic or abdominal aortic aneurysm sclerosis is kind of a buildup within the aorta that causes narrowing, and aortic aneurysms are a weakening of the vessel of the big aorta, which is a big blood supply that goes from your heart to your abdomen and your lower extremities. In the U.S., since 1975, the mortality has declined, which is good news. A lot of that's happened through better eating, education, and that's interesting because we've been living longer, so that even says more. And we'll see some graphs here in a future upcoming here. It's been estimated that nearly half of the decline is due to earlier diagnosis and more aggressive treatment, particularly with medical therapies that are available now. Sorry about that. So you can see that the total deaths kind of went up, and now they're starting to decline. So that's what that last sentence was kind of saying. You can kind of see that heart disease is total cardiovascular disease. The second line is heart disease. This is our coronary heart disease, and then this is our stroke. Stroke's been on the lower level, but you can see it still stays about the same. But most of these have kind of gone down.
Jenna, why such the high spike? I mean, what was causing it to die?
Well, they're thinking that here we didn't have a lot of the medical therapies, a lot of the knowledge about heart disease and strokes. So that's the incline. Nurses Health Study for over 20 years, women who maintained a desirable weight, ate a healthy diet, exercised regularly, did not smoke cigarettes, experienced an 84% reduction in their risk of clinical cardiovascular events. You will see a common theme in all these slides. For those of you who smoke, did I say for those of you who smoke? Okay, okay. So this is a really important slide for those of you who smoke. Additive effects. You can just see that the more things you have, if you're a smoker and a male, you get to the male here and you get older, you notice there's more events than being younger, and being female maybe with no risk factors. Which is called the additive effects of having a bunch of things that make you more at risk for having a major event. Atherosclerosis is responsible for almost all of the cases of coronary heart disease. It's an insidious or slow-growing process. It begins with fatty streaks that are first seen in adolescence. And that's important because our teenagers that are overweight and don't eat right, we're really setting them up for this whole process later on in life. These lesions progress into plaques, and then in early adulthood, they accumulate into thrombotic occlusions, and what that means is blood clots can form around them. They actually become almost like the flaky pie crust that kind of start to flake off. And there's actually something called shattering that's when they flake off and then they occlude vessels in the lower extremities because they're, flaking off, plugging up vessels. And they can affect many, as you can well imagine, blood vessels throughout the body, kidneys, stomach. They can flake off anywhere. In coronary events in middle age and later in life. And then you add your genetics to it, and that always can make it worse or better too, based on how your genetics are, family history. The Framingham Heart Study you'll hear a lot about. There's a Framingham Heart Study went over 20 years. They've looked at cardiovascular disease, things that work, don't work. It's been one of the longer range studies, and they've learned a lot from it because they have the same group of people that were committed to this study for the entire length of time. So they kind of know what works and doesn't work. Our simvastatin or our statins came out of the Framingham Heart Study. Our aspirin recommendations came out of the Framingham Heart Study. So if you're wondering how we know about that stuff, it's because they've done this long study and found out that it's just worth it. You know, the benefit far outweighs any risk. The major cardiac risk factors were defined as a cholesterol greater than or equal to 240, systolic blood pressure greater than 140. We'll talk about blood pressure parameters, but the recommendation from JNC7, which is an evidence-based guideline based on a lot of other research, is that anyone without diabetes should have a blood pressure less than 140 over 90. If you're diabetic, the ICSI.org, ICSI is another research-based, very well-known, evidence-based organization that does a lot of research. For diabetics, it's under 130 over 80. So they want a lot less for diabetics. And we'll talk about why that is coming up. Diastolic blood pressure less than or equal to 90. No surprise, smoking is next, and diabetes. Cardiovascular risk factors promote cardiovascular disease, diabetes, and a high density lipoprotein. And this is actually a low HDL. You want it high. I always remember H is for high, L is for low. So you want your HDL, your good cholesterol, to be high, and your LDL, which is your bad cholesterol, to be low. So when you have a low high density lipoprotein, that's not good. If you're diabetic or your total cholesterol ratios are not in the range, that is a real problem. The incidence of myocardial infarction has increased 6-fold in women and 3-fold in men who smoke. Amazing, smoking again. At least 20 cigarettes per day compared to subjects who never smoked. And you'll learn about exercise here too, because I pick on exercise a lot, and I pick on some of the lab values we can't do much about. I mean, we can do exercise and we can eat, but sometimes our genetics are part of it. So we'll talk about the things that are modifiable are the things we do to ourselves. It's what we eat, if we smoke or not, or if we don't exercise, versus the things we're born with, whether we're male or female. You know, ordinarily you can't change those things. Systolic blood pressure and isolated systolic hypertension are major risk factors at all ages and in both genders. So we don't want elevated systolic or top numbers of the blood pressure to be high. The Framingham study found that relative importance of systolic, diastolic, and pulse pressure. And pulse pressure is the difference between the top number and the bottom number of the blood pressure. It does change with age. In patients less than 50 years of age, diastolic blood pressure, which is the bottom number of the number that you get when you check your blood pressure, which is your heart at rest, was the strongest predictor of CHD risk. So if your heart's not resting, it's not resting. If that number's high, your heart's not resting very well. So we want to keep those numbers low. And in those 50 to 59 years of age, all three blood pressure indices are, all those three things above were comparable predictors of coronary heart disease. And we do look at more systolic blood pressure in people that are over 60, and also that pulse pressure. We subtract the top number from the bottom number and get a pulse pressure. We look at that and top number for predicting cardiovascular disease. Some risk factors such as dyslipidemia, which is high cholesterol, impaired glucose tolerance, which is high sugars that are like pre-diabetes or not diabetes yet. Elevated fibrinogen is your fibrinogen is what helps the blood clot, have a diminished impact with advancing age. Thus, all of the major risk factors continue to be relevant in older persons. And then, of course, obesity and weight, and thus our weight loss class promotes or aggravates all the atherogenic risk factors, and physical inactivity. And here again, I think on exercise, worsen some of them predisposing subjects to all these events. And it's kind of like if you're not burning it off in your body, then it's sticking somewhere. So I'm still trying to get rid of our. And this is just the lifetime risk. It talks about the Framingham Heart Study again, and it talks about if you. This is the cumulative effect. So someone with not very many risk factors, have a certain amount of risk, and then if you add another major risk factor, you have more risk of having an event. And then if you have two major risk factors, and you have, so if you add diabetes and smoking, for example, you go from here to here, and you significantly increase your risk. So it's just more of a visual than it is new information. You'll hear a lot about primary, secondary, and tertiary kind of interventions in the healthcare world. Primary is anything we do for prevention. Secondary, and that might be exercise and eat right. And secondary prevention might be the screenings we do for cholesterol to see if we're high and we need to treat it. Tertiary is reducing complications. That's for the person who's already had a stroke and we want to rehab them and get them fully functioning. And so we'll do tertiary interventions for them. Primary prevention for cardiovascular disease and modifiable is those things that we've kind of briefly talked about, which is diet, smoking, treating high blood pressure, high cholesterol, physical inactivity, obesity, diabetes, and in some evidence-based medicine, and because there's so much research out there that people that are diabetic have a 6-fold increase of having an event meaning stroke or heart attack. It's a risk factor kind of equivalent all in itself. And heavy alcohol use. And it's usually 1 drink for women, 6 ounces of wine, 1 beer, or 2 for men. That's kind of what the guidelines kind of state as anything above that is heavy alcohol use. Hypertension is a well-established risk factor, including morbidity and mortality. Morbidity is how much it impairs you. Mortality is whether it kills you. From stroke, coronary heart disease, heart failure, and sudden death. So the bottom line is we want to control blood pressure. I don't know why this is doing this, but this is just a plug for if you have hypertension or you have diabetes, and I'll show you some quick slides of a diabetic eye, is there are certain things that we can see, that even I can see in the family practice realm to look for hypertension. And so if I didn't take someone's blood pressure and they've had blood pressure and had been high for a while, we have what they call AV nicking. And usually you'll see these like little narrow spots where the blood vessels are. And that's it's a hypertensive retinopathy can occur too, which is where that arrow is over there. There's a little bit of optic disc kind of blurring. If you have your indistinct borders, you can't really tell where the blood vessel is. It's kind of blurred. So those are things that we look for when we do our annual exams. Then we get into the harmful dietary fats, the 2 main types of potentially harmful dietary fat. We talked about this in our weight loss class yesterday. Saturated fat is fat that is solid at room temperature. We think of Crisco, for example, or butter. It comes mainly from animal sources of food. It raises total blood cholesterol levels and that LDL. Remember that LDL we want low, not high. And it can increase your risk of heart disease. Saturated fat can also increase your risk of type 2 diabetes. Trans fats are the ones they take, they have to label them now if a food has trans fat, because it was so bad for people that a lot of foods now say no trans fats. This is a type of fat that occurs naturally in some foods, especially foods from animals, but most trans fats are made during food processing. So if you read a label that says hydrogenated oils, hydrogenated means it's been processed in such a way that it's become unhealthy. So if you see hydrogenated, then stay away from it if you can. They're easy to cook with and less likely to spoil, is why those became so popular in years gone by. And then the research has shown that these synthetic trans fats can increase the unhealthy LDL cholesterol and lower your high density, which is what we want high, right? And most fats have a high percentage of saturated fat or trans fat or solid at room temperature. Because of this, we're typically referred to as solid fats, and again, the beef, steak margarines. And then 2 healthier ones, monounsaturated. When you look at the label and you're doing label reading, which I don't know if many of you do, but it'll say fats, it'll say total grams of fat, and it'll break it down to saturated fats, and then it'll say monounsaturated and polyunsaturated. So if you've got a total fat of 22, but most of them are poly and monounsaturated, that's better than having a high, like, saturated fat. If you go look at hot dogs or bratwurst, you're going to see a really high saturated fat. So these are some of your foods and oils, and they're thought to kind of decrease your risk of heart disease. And then research also shows that these monounsaturated fats, which are MUFAs, may benefit insulin levels and blood sugar control, especially which is helpful in type 2 diabetes. And then polyunsaturated, a better fat called PUFAs, improve blood cholesterol levels. What? PUFAs and PUFAs. And those are some of the fatty, we'll have polyunsaturated with some of your fishes and so forth that are good for lowering cholesterol, have the polyunsaturated fat in them. Foods made up mostly of the mono and polyunsaturated fats are liquid at room temperatures, and those are things like your olive oil, sapphire oil, peanut, corn oil. But to also remember, there's still fats though, and there's still calories. So when you're trying to eat a healthy diet, you don't want to just eat excess of those. But if you're substituting them for the saturated ones, of course, that's the first step of improvement. So guidelines also recognize the importance of type of fat. Consume less than 10% of calories from saturated fatty acids by replacing them with the other two like we talked about. Consume less than 300 milligrams a day of dietary cholesterol. Most labels will tell you milligrams of cholesterol. You keep your trans fatty acid consumption as low as possible, and I think most fats now, they've almost like obliterated, they've just taken trans fats out of their foods. Or they're so negligible they don't even have to report them. Reduce the intake of calories from solid fats and added sugars. Because remember, if you eat too much sugar and carbohydrates, what happens to that? It stores as fat, right? Replace protein foods that are higher in solid fats with choices that are lower in solid fats and calories and are more, or resources of oil, so it's like having fish instead of beef. Use oils to replace solid fats where possible. Some people even use applesauce instead of oils, like in their recipes, to make it moister. Wasn't it you that did that? Yeah.
I've done that before. Works
Yeah.
well. Pumpkin works too.
Pumpkin?
Mm-hmm.
Yeah. So there's some really good alternatives nowadays that we do. Okay, secondary prevention, this has already happened or you're screening it. Therapeutic lifestyle change in the form of increased physical activity, most of you know this, dietary modification, weight loss, smoking cessation are all proven benefit and may improve outcomes as quickly as 6 months. That's pretty phenomenal that it would happen that quickly. The other medications that we've talked about are aspirin, statins, and in patients with a heart attack or heart failure, other medications like beta blockers or ACE inhibitors, there's other medications that help heart function, are usually prescribed. And then we talk about hyperglycemia, which is high blood sugar. There's a graded rise in cardiovascular risk with increasing blood sugar in patients with overt diabetes. And we're finding more and more now that studies are coming out about prediabetes, that having elevated blood sugars from time to time increases our risk. And it just, our blood vessels tend to, as you all know, people have decreased circulation in their legs with diabetes, and it can happen in their kidneys and their eyes, and so it's felt that, we know that they're more at risk for heart disease because it plugs up the vessels in their heart as well. The magnitude of this effect was illustrated in a 13 perspective cohort study, which is a pretty big study, done in the United Kingdom. That's what UK PDS, they do a lot of studies. For every 1 percentage point increase in, for every 1 percentage point, hemoglobin A1C is an average blood sugar of 2 to 3 months. And so what they're saying is that the increase of the hemoglobin A1C by 1% would increase the risk by 1.18, which is a pretty significant number. And likewise, if you reduce it, of course, you help those numbers. Oh, smoking. As a non-diabetic, smoking in diabetics increases cardiovascular morbidity and mortality, raises your LDL cholesterol, and impair your, what's so funny?
Isn't this class is for you too?
You said it, not me. All right. Dyslipidemia, there are a number of differences in the lipid profile between diabetics and non-diabetics that may contribute to the increase in atherosclerosis. The serum lipid abnormalities differ somewhat in patients with type 1 and type 1 diabetes. Type 1 primarily because it's more of an autoimmune. They think that the pancreas is destroyed by a virus or genetics. Type 2 diabetes is more of the pancreas kind of just giving out, but you still have some function, and you have highs and lows like you can with type 1 diabetes. But you'll find that the HDLs in diabetic patients will generally be lower than patients of the general population. So there are, when you do their fasting cholesterol in a diabetic patient, there are just some inherent differences, and they're finding some common trends in those lipid profiles among diabetic patients. Pathogenesis just means the progression of or development of diabetes. Patients present with a combination of varying degrees of insulin resistance, That means that the sugars are high because the insulin that you have isn't working very well in your body. Your body's resistant kind of to the insulin, and so your sugars just keep climbing. And it's likely that both contribute to type 2 diabetes, both the insulin resistance and the relative insulin deficiency. Because if your pancreas isn't working as well, it's not giving you as much insulin, and the insulin you do have, your body doesn't recognize it very well, which is why some type 2 diabetics who have some insulin production will get insulin, because you have to get above a certain threshold for the body to be able to use it and not be so resistant. Type 1 diabetes is related to insulin deficiency. Islet cells are just cells within the pancreas that produce insulin. And so with type 1 diabetes, you have a virus or whatever causes it. You wipe out all your islet cells in your pancreas, and if they don't get insulin, they eventually will die because they don't have any insulin on board to get them through. Where type 2, you always have some production of insulin. It may be resistant or not enough. Symptoms usually are due to hyperglycemia, which is the elevated blood sugar, and commonly include polyuria, which is lots of urine. Polydipsia means lots of thirst, and having to go to the bathroom at night, similar to that seen in patients with type 1 diabetes. A recent weight loss is less frequently reported in children who present with type 2. So what's happening in type 1 is you don't have any insulin, your sugars are going up, your body thinks it's starving, and it's breaking down fat pretty fast trying to give you sugar. The problem is the breaking down of fat is trying to give you more sugar, but your body can't deal with it. It can't do anything with it because there's no insulin on board. So you don't have that usually in type 2. You can have a relative insulin deficiency where I'll see some patients will have some minor weight loss in a what I call relative deficient. They call it a 1.5 diabetes or a type 2 relative insulin deficient patient. Many patients with type 2 diabetes are identified by screening. That's that secondary prevention that we do, usually annually for our patients here. We do a hemoglobin A1C, are asymptomatic, and they don't have any symptoms. Women might come and present with just a bladder infection. Men often will come in because they're impotent or having some sexual dysfunction, and then you do blood sugar on them and you find out that their blood sugars are too high. This occurs as a result of the screening specifically for type 2 diabetes or because of positive urinalysis tests, we talked about that, or just routine physical examination. The patient says they're really tired, they just can't get it together, and they look like they're kind of depressed, but you check their blood sugar and it's 500-600. Diagnosis, in a nutshell, we don't do the oral glucose tolerance test much anymore. We usually do a couple fasting morning blood sugars first thing in the morning. If it's greater than 126, then that's a diagnosis of diabetes. If it's 200 and someone's having those symptoms we talked about, where they're urinating a lot or thirsty a lot, that's a diagnosis. Or if their hemoglobin A1C is greater than 6.5. 5.6 to 6.4 is prediabetes. So we are actually diagnosing prediabetes now off the hemoglobin A1C in that range according to the American Diabetes Association and the ICSI guidelines. Prediabetes, 5.7, 6.4. Following factors are associated with increased risk for childhood onset type 2 diabetes. No surprise, the heavier that we are, the more resistant we are of insulin. Our insulin is more resistant, our cells are resistant. And so if people can lose weight, your cells become more sensitive to the insulin. And you don't have as much, you have to maintain. You've got less body fat too. Positive family history, specific ethnic groups, things like Black Americans, Indian, Asian populations are groups of people that would be more at risk for diabetes. Female gender, I don't know why that is. And conditions with insulin resistance like we talked about. Lipid pattern in patients with diabetes is largely related to glycemic control. You'll hear a lot about in the studies, for those in the healthcare realm, of the DCCT trial. That's the Diabetes Control and Complications trial. That is where they really, at the United Kingdom, did this study. And that's where metformin came out of. It's a drug that we commonly use. They also, out of this study, came the tight insulin control with insulin. Found that patients with type 1 diabetes with a mean hemoglobin A1C of 8.8% had similar serum lipid values as non-diabetic individuals. So the whole take-home message was if we can get their hemoglobin A1C down, then their lipid panel or their glycemic or their cholesterol testing would be very similar to someone who wasn't diabetic, which would then reduce their risk for these events. And they gave, except for young women. Among patients with type 2 diabetes, insulin resistance and the deficiency we talked about in obesity are associated with this hyper means high, triglyceride is our part of the cholesterol, which is fats, and glyceridemia, it just means high glucose, and emia means in the blood. And then you have a low HDL, remember H is high, so we want it high, and it's low instead. Cholesterol concentrations, and occasionally a high serum LDL. Remember, we want the LDL to be low. This pattern of lipid abnormalities can be detected before the onset of overt hyperglycemia. So we can, if we look carefully to people's lipid panels, we can almost, see, especially with a family history of diabetes, if you start to show these kinds of lipid panels or cholesterol results, we start to think that maybe you have a propensity towards diabetes. And then we just do education, diet, exercise, eat right. Diet complications, keeping blood sugar low is important as preventing the complications. Eye diseases that lead to vision loss or blindness. If your sugars are high and low all the time, you have a lot of water going in and out. It's almost like looking under a swimming pool. And you'll have a diabetic tell you, my eyes are blurry, and you'll say, well, is it like swimming under a swimming pool? And they say, yeah, And that's usually because of their the blood sugars and the fluid in their eye. Kidney disease, obviously, nerve damage, we call neuropathy, can cause numbness, pain, kind of walking on sponges is how diabetics will talk about how it feels. They need to have their toes, fingers, and other body parts removed from surgery or amputated because they lose circulation due to infection or lack of blood supply. Diabetic retinopathy is really hard to see this, but what happens with diabetes is that these blood vessels, as you develop new blood vessels within the eye because of these high sugars and these fluctuating sugars, the new ones become very fragile and they start to bleed. And so when we do an eye exam in the primary care office, we'll notice little hemorrhages. And those hemorrhages, if it gets in the right part of the eye, you see an image outside, it goes to the back of the eye, and your brain interprets what you're looking at, and then you know what you're seeing, right? Well, if it occurs in the wrong place, that vision isn't clear and can't be interpreted properly, and that's when that vision deficit and blindness occurs with diabetes. So if anyone's diabetic in here, and you can see for reasons of high blood pressure and for diabetes, it's really important to see your eye doctor every year. Goals are to keep your A1C levels below 7%. Folks over the age of 60, 65, depending on their comorbid conditions, below 8% is recommended because they have the risk of falling if they run too low, trying to drive down their blood sugars. Blood pressure below 130/80, we talked about that. LDL cholesterol below 100. The other, with diabetes, the recommendations from ICSI and the American Diabetes Association, JNC7, are all, they want an LDL less than 70. So if someone has a 78, LDL, we don't necessarily add statins or cholesterol-lowering medications, but we do want them around that number. And then definitely most individuals, with few exceptions, we want you under 100. So if you're not, we're going to be talking about diet and exercise. Multifactorial means lots of reasons why there's risk reduction. Vigorous cardiac risk reduction, again, smoking cessation, aspirin, blood pressure control, reduction in those serum lipids. We use statins, and we actually use red yeast rice a lot, which is like a statin. It's over the counter, a natural product. People that get muscle discomfort with red yeast rice or statins can take a CoQ10. And another product that works really good to clear the liver, for alcoholic livers even, is milk thistle. And so milk thistle has been very helpful. And we do recommend that for patients that end up with some myopathies or muscle pain with either the statin or red yeast rice even. Diet, exercise, and in high-risk patients, adding ACE inhibitor. ACE inhibitors actually are recommended for almost any disease process. MI, which is a heart attack, we use it in congestive heart failure, diabetes. We use it in diabetes even when people don't have high blood pressure. We do that because we want to protect the kidneys. And for the most part it does. I mean, there are some kidney changes that occur, which sometimes we have to reduce the dose or take them off, but rarely. So those are your usual. We don't have to pay attention to this side here because this is for Europe. We're not in Europe. So people ask, well, if my hemoglobin A1C is 10, what is my sugar? And remember, it's kind of an average blood sugar. So if someone's hemoglobin A1C is 10, that means their average blood sugar is running about 240 all the time if you averaged them all together. If you took 10 blood sugars and divided by 10, you got an average, it would be about 240. So you can see that if we want them to be around a 7 or under, we want their blood sugar to average about 154. That means they're high after eating and they're low when they wake up, an average of 154. That's not a whole lot. Lifestyle changes. And you can see there's a lot of repetition in these slides about lifestyle changes. Choices you make every day and the way you eat and live really have an impact on your health. That's kind of a take-home message. Make healthy food choices, eat lots of fruits, vegetables, whole grains. 100% wheat doesn't mean whole grain. It has to say 100% whole wheat. So reading labels is helpful because it really can just be a little bit of, when they break the whole wheat apart, there's some of the shells and stuff, and they can throw that into a flour and they can call it 100% wheat. And low-fat dairy products, and limited amount of meat or fried or fatty foods you eat. If you can broil something versus fry it, that's always best. Lose weight, being overweight increases the risk of many health problems. Your joints hurt, your heart, it's hard on your heart because you gotta circulate blood to more areas, and avoid alcohol. And alcohol can increase blood sugars and blood pressure, but in moderation, it's not proven to be harmful. So I don't like the word avoid. I mean, just in moderation with the recommendations. Be active, walk, garden, do something active for 30 minutes on most days of the week. And it isn't exercise, it's just moving. We're learning that in our diet, our weight loss class too. It's not about going out and getting a brisk walk and getting short of breath and seeing how hard you can sweat. It's really all about just moving more. I mean, fishing is considering an exercise if you enjoy to do that. Stop smoking. Smoking increases the chance that you'll have a heart attack or stroke or develop cancer. So, did I say that? Have we heard a lot about exercise, smoking, diet? Okay, I just have to harangue a couple friends here. And I may not be their friend after this meeting, but I better make it go out. Better go out good. Last, I want to tell you, I've got some handouts available on all these topics. And if you want to, there's a list here, and if you put your name on it, just draw a line under the last name so we know it's from this class. But there's a list of all the handouts and copies of the handouts, so if you want to know what's in the handout as far as content or information, maybe you got a mom or dad you want to send it to, and but we'll make copies for you. So just sign up on this sheet and put the number of the article you want. They're all numbered. So if you want number 5, which is the patient information, health risks of obesity, the basics, then you put number 5 and put your name, and we'll know that's the article you want. And again, this book is available in my office. You can come and look and check out the articles. Or if your department wants to have the book for a while and take a look at it, that's good. And these are just, again, the handouts. Any questions?
It's about preparing food. As far as grilling, is grilling a healthy way to make food? Or I've heard so many different things. I've heard that
it is charcoal colon cancer.
Is it okay to grill your food?
Well, most people take a brush and they kind of brush off the most that they can, and it's certainly healthier than frying.
It is. Okay,
yeah.
That's why I was wondering, because I've heard it's like
carcinogen, the burn.
Horrible for you. So.
And that's the best part.
And that smoke is there.
And that smoke, yeah. But isn't that smell good? That's what I grill. I want to smell good.
What's the high HDL? I mean, what's the number supposed to be at for the HDL? You said that LDL needs to be below 100.
Above 40.
Above 40.
Mm-hmm. Yeah. Anything above 40 is good. And the higher the better. So like my HDL runs about 70 to 80. That's high. We have no diabetes in our family. My LDL runs about 67, which is just amazing. And my total cholesterol, I know that makes you sick, 167. Now, if I was diabetic, I'd probably have a 35 or 30 HDL. My LDL might look like 110. My total cholesterol maybe 225.
So the HDL is the one that kind of screens for diabetes? Or they
No,
both?
that's hemoglobin A1C.
So what's the HDL? I know when we talked
That's the
about.
part of the cholesterol that's the good cholesterol, and you want that to be higher.
See, mine is low. Mine is bad. My HDL is bad, and so we have a history of diabetes in our family. But I get my blood taken all the time. But I was wondering if that's part of the reason why, because it's not like I'm not active. But.
Well, you saw the whole study about the trends they see amongst people that have genetically inclined to have diabetes, what their cholesterol profiles look like. You've just spoken to it.
But what about my LDL? My LDL is good. Is that okay? Or I mean.
Yeah, if your LDL is good, that's the first thing we look at.
I don't know if there's, if I stay active, I am. Can you do anything to help?
Exercise brings up your HDL, and good eating will bring up your HDL. And other than statins, different medications that you can prescribe to change your lipid profile, you're really doing everything you can. You're weight appropriate, you're eating right.
Okay.
And do we always eat right? No. Hence our diet weight loss class last night. Any questions? All right. You can turn that off.